Welcome back to Medication Management in Patients with Advanced Illnesses. This is Module 3, Non-Pain Symptom Assessment and Management, Part 2. I'm Dr. Diana Stewart. I have with me Dr. Lynn McPherson and Dr. Nicole Brandt. The objectives for Part 2 are to be able to describe the presentation and common causes of cardiorespiratory symptoms at end of life, given a patient case, identify some red flags, and list one medication and one non-medication treatment option for cardiorespiratory symptoms. Just so you know where we're headed today, the first symptom we'll discuss is dyspnea or difficulty breathing, and then we'll get into discussion of secretions and noisy respirations. Dyspnea refers to difficult or labored breathing and is also used to describe feelings of extreme shortness of breath or feelings of breathlessness. Dyspnea is very distressing to patients. They may feel like they're at risk of suffocating, and caregivers often feel helpless to relieve this symptom. And this is different from Cheyenne-Stokes breathing. So Dr. McPherson, what is Cheyenne-Stokes breathing?
I don't know. Why don't you tell me? What is Cheyenne-Stokes breathing?
So this is changes that are experienced when a patient is going through the dying process. So they'll have kind of a speeding up and a slowing down pattern, whereas dyspnea is kind of this constant feeling of a difficulty breathing. Anything to add, Dr. Brandt?
No, I think that's a good description.
How do we get dyspnea? Some common causes are infection, such as a pneumonia, lung cancer, and actually heart failure is a common cause. When the heart can't pump effectively, you get a backup of fluid into the lungs, and patients get this overwhelming feeling of difficulty breathing. For the treatment of dyspnea, we always want to involve non-medication therapies. Some of the best ways to manage it are to sit the patient up and elevate the head of the bed if they're lying down. And this just helps change the position of the fluid in the lungs and can allow them to breathe easier. Place the patient near an open window or fan. Just the sensation of the air movement can relieve that feeling of breathlessness or air hunger.
Boy, that open window in downtown Baltimore in January might be a little tricky, what with getting a foot of snow at a time, huh?
You get a little bit of a chill blast with that too. You can also utilize guided breathing techniques, and these just help patients to slow down their breathing and be more focused on the process of breathing in and out, and relaxation techniques. Medication therapy. So is oxygen therapy a medication? When you're using it for the treatment of a symptom such as dyspnea, it is considered a medication. We also have bronchodilators available, such as ipratropium or Atrovent, or albuterol, which is a common one that you'll see used as needed for feelings of dyspnea or difficulty breathing. If the feeling of breathlessness is due to cough, you can use cough suppressants like codeine or dextromethorphan, or if it's due to an infection, treat it with an antibiotic. Medication therapy. So anti-anxiety medications can actually be used for the management of dyspnea, but what these really treat are the feelings of breathlessness and the anxiety associated with the dyspnea. Diuretics or fluid pills can reduce the buildup of fluid in the lungs due to heart failure and again relieve the cause of dyspnea. And opioids. Dr. McPherson, what are opioids doing on this list?
I don't know. That seems pretty crazy, doesn't it? Especially when we consider people who have chronic obstructive pulmonary disease, or COPD. You're already worried that they're not breathing well, and here you're using medications that have been shown to slow respirations. So paradoxically, we have seen that it does not, in fact, worsen their breathing pattern, but it does relieve this sensation of difficulty breathing, which can be so many different presentations. Some people say it's harder to breathe in than to breathe out. It could be the other way, harder to breathe out or to breathe in. Some people feel like the air doesn't go all the way down to the bottom of their lungs. They have to struggle to get the air in. And taking an opioid either on an as-needed or a scheduled basis can provide tremendous relief.
So it's not intuitive, but it is a great treatment. Moving on to noisy respirations. These are moist, noisy respirations that are sometimes referred to as death rattle. Dr. Brandt, do you think this is something that family members would want to hear about, this death rattle?
Oh, no, it's very problematic and distressful to them, especially, in terms of just wondering what they can do to resolve it.
Absolutely. Sometimes the family will come running out of the room and say, oh my God, they're choking, or what is this noise? It almost sounds like snoring sometimes. And again, we want to be careful not to use the term death rattle around families because that is not really a good connotation. But what causes this? It's from the pooling of oral and respiratory secretions at the back of the throat. And when patients are unable to cough and adequately clear the secretions, you get a pooling of these in the back of the throat. And then as the patient breathes in and out, you'll hear the noise of the air traveling through those secretions. This is more common in patients who are comatose or as death nears. How do we manage it? Again, non-medication therapies are very important for the management of noisy respirations. Position the body to reduce the pooling of fluids in the back of the throat. And this is another situation where decreasing fluid intake can reduce the symptoms. Perform gentle oral care to clean secretions if possible, but you only want to perform gentle suctioning if you can actually visualize the secretions in the patient's mouth. Deep suctioning is incredibly uncomfortable for the patient and can actually stimulate more secretions, so once you clear it out, you'll just get more right behind it. Again, provide education and reassurance to family and caregivers. The presence of noisy respirations does not necessarily mean that the patient is not breathing adequately. It's really just due to the sound as the air moves through the throat.
And another important point is it's more distressing to the family than it is to the patient themselves. But it's sometimes hard for people to believe that. They're not suffering.
Absolutely. So what do we have in terms of medication management? We rely on things that will help dry up secretions and ideally prevent more secretions from forming. A few of the options are scopolamine or transdermal scope, and this is a little transdermal patch that we typically apply behind the patient's ear. However, this will take a few hours, typically about 12 hours before it really kicks in, so it's not a right-away fix. Atropine ophthalmic drops, you can actually give these eye drops orally in the mouth to dry up secretions. And then hyoscamine and glycopyrrolate are just other options for relieving noisy respirations. Moving on to a case, during your visit at the nursing home, you get called into a patient's room by the nursing aide. The aide is very concerned about this gargling noise when the patient breathes, and she's afraid that the patient is choking. How would you go about treating this patient's noisy respirations? So why don't you take a minute to think about it? So actually, both A and B are correct. You could initiate a transdermal scopolamine patch to help dry up the secretions, but also sit the patient up in bed to allow those secretions to clear, and that will provide a more immediate fix while you're waiting for the patch to kick in.
I think that repositioning is such an important educational point for both professional caregivers and for families. Just yesterday, a hospice nurse called me. We had a patient already on the atropine drops. The patient was very close to death. She wanted to start a transderm scope patch, and I pointed out, which is what you said, that it can take too long to really kick in for the time the patient had left, and I suggested that she prop the patient up to about 30 degrees and roll them onto their left side. And in fact, that did the trick, and the family was relieved to have that happen.
I do love a quick fix, especially if it's easy like that. And like we mentioned before, you want to avoid doing any kind of deep suctioning. This will just worsen the experience for the patient. And that was a relatively quick module. So that concludes part 2 of non-pain symptom assessment and management. And we'll see you back here for module 3, part 3.